Hello, everybody, and welcome back to the Beat Podcast here at Health. I am thrilled to have a guest with us, a phenomenal leader in healthcare and a repeat guest. His name is Charlie Harp. He is the CEO of Clinical Architecture, and he also founded the organization. He's an industry-leading healthcare data quality solutions provider, and Charlie has over 30 years of experience.
Hey, now, you're making me sound like I'm old.
He's just great at what he does. Let's just say it.
All right, I'll accept that.
Charlie, such a pleasure to be with you again.
It's great to be here, Saul. Thanks for having me on.
How's the event going for you?
The event's been great. We had a great panel discussion yesterday talking about data quality, walking around. It's always great to connect with all the people at all these conferences we go to. And there's a lot of talk about data quality, which I've been waiting 35 years to get to the point where we're talking about data quality. So I'm happy.
That's great. I'm really happy to hear that. And yeah, with everything that's needed and all the things that are happening with AI, you need great data to make it happen.
Yeah. AI, artificial intelligence on bad data is artificial stupidity. And we don't need artificial stupidity in healthcare.
That's going on a bumper sticker.
Yeah, I believe so.
Charlie, so let's dig in. Talk to us about clinical architecture. How are you and the organization reimagining care delivery to improve both access and outcomes, especially for historically underserved populations?
So I think when you look at what clinical architecture does, and when I started the company 18 years ago, it was all about the plumbing. When we start to go down this path in healthcare of sharing data for patients across the entire spectrum of patients in healthcare, if the data quality isn't good, if it's not interoperable, if we can't complete the picture, regardless of whether we're talking about things like meds or labs or social determinants of health, we want to do all these meaningful things. But for that to work, we've got to have good plumbing. Having pipes that deliver something that's not drinkable is not going to help anybody, whether you're talking about over or underserved populations.
Yeah, no, it's important. And you definitely had a vision for it. And I never asked you, but why did you start it? Why did you start the company?
I did a talk recently where I said back in 2007, I left the Hearst Corporation because I really felt like healthcare was on the verge of becoming a modern, data-driven ecosystem. Now, yes, my timing's not great, and I'm an optimist. And then in 2010, the HITECH Act passed, and I thought, oh, here we go. Now it's going to happen. In reality, I started clinical architecture because after working in clinical labs, clinical trials, clinical decision support, evidence-based medicine, I really felt like there wasn't anybody that was focusing on the plumbing because it's not sexy.
Yeah.
What we do at clinical architecture, improving the quality of data and doing it in a way where we minimize the human casualties, because healthcare can be a bit of a sweatshop when it comes to working with data. Our goal was to be able to serve the uses in healthcare, whether you're talking about something exciting like AI, or you're talking about things like clinical decision support, quality measures, HEDIS measures, population health, value-based care, all of those things. They might not be as sexy as artificial intelligence is right now, but they all need good data to operate. And so clinical architecture, the name clinical architecture, was because I felt like healthcare needed a clinical architecture to drive all of this capability around data quality in healthcare. I was just a little ahead of my time, just by a decade.
You definitely had the vision for it and the tenacity to really wait this time, build, and now is your moment. With so many emerging technologies we see here on the show floor, shaping the future of health, how do you decide which innovations to invest in, and how do you measure their real-world impact?
I think to measure the impact of any piece of tech, what you're really looking for is you're looking at what does it drive? What does it give you at the end of the day? The biggest challenge we have in healthcare, and this is why I'm excited to talk about data quality, the biggest challenge we have right now is we have some really great technology, some really great opportunities, but if we don't have good data to feed into that technology, whatever it is, it's not going to deliver dividends. And one of the challenges we have in healthcare is sometimes we take a perfectly good technology, we try to apply it, and we don't apply it appropriately. And then we say, oh, this technology doesn't work, and we get rid of it. I think with AI, there's a particularly high risk because AI is an accelerant at the end of the day. There's a particular high risk where if it's trained on bad data, and we prompt it with bad data, it's going to hurt somebody. And once it seriously hurts somebody or two somebodies or 1,000 somebodies, we're going to say this technology won't work and we're going to pitch it out just because we didn't really apply it appropriately. So when I look at any of these solutions that are out there, whether it's AI, whether it's something that facilitates quality measures, it really comes down to what are you putting in it? Are you putting good data in it? Because if you're not, it doesn't matter how good the tech is, it's not going to work.
Amen to that. I love that. That's been a different answer than others that we've gotten today. So I appreciate that fresh approach.
Controversy.
Stir it up, Charlie.
Bring it.
All right. So we talked about how you've been working on this for 18 years. This next question's probably more short-term for you. Ahead, 3 to 5 years from now, what bold bet is your company making that you believe will truly transform the healthcare experience?
So about 2 years ago, I started working on this project called the Patient Information Quality Improvement Framework. It's PIQI, P-I-Q-I.
Yeah.
And since then, with help from people across the industry, people like Levitt Partners, the VA, CMS, and a number of others, we've decided to put it out in the open source. And the idea is it's a tool for objectively measuring the quality of the data we're exchanging in healthcare. Because right now, as we stand up TEFCA and we stand up these QHINs and we say you really should be sharing data with each other, the truth of the matter is people, they don't trust the data. Trust is the last barrier to interoperability. And so what PIQI does is, and the reason why I wanted to do this, and not just as a product, but to do it as an HL7 standard, do it as something that's open source. And this is what I said to my team. We're at a point where we could make a product or we could make a difference. And for me, PIQI is something that if it's adopted across the industry, if it's embraced by folks like CMS and others, it'll create something that monitors and measures the quality of the data that we're trying to use. Because if you care about something, you measure it. If you don't measure it, you don't know anything about it. And when we talk about going back to the sources and saying you need to fix your data, they don't know their data is bad because no one's ever measured it and showed them this is what's wrong with your data. So the big bet we're making is that the PIQI framework and the PIQI Alliance working together can establish these rubrics that will be the rising tide that raises the boats of healthcare in terms of quality, so we can get on with meaningful work in healthcare and not keep throwing our hands up and say the quality is not good. I'm not getting good data out of the system. So that is, I think it could be a transformative moment in healthcare if we have a way to actually look at each other and say, your quality is good and your quality is bad, and here's what you need to do to fix it.
That's great. Yeah, it's a measurement system that allows for standardization, finally, to be able to do more with it.
Exactly.
There's a lot of stakeholders in healthcare, and so I always like to ask the question about what stakeholders can benefit the most out of the frameworks that you're building.
I think that when it comes to improving the quality and usability of data, because really quality is about usability. The minute you do that, when you get to good quality, it's a tipping point for usability. And once we get to usability, not only will we improve things for organizations that are trying to optimize care, manage their cost curve. When you think about CMS, worried about fraud and abuse in the system, good data, that tipping point, not only helps all those people from a business perspective, but ultimately it helps you and me and patients just like us, because the systems are able to make better decisions. It's all the AI that they're going to bring about, which could also be a transformative tool, can make better decisions and come to better conclusions that help us as patients. Because at the end of the day, when you think about our remit in healthcare, there's all these things, there's paying for this and doing that and managing this. But at the end of the day, what we're really trying to do is we're trying to create people that are healthier and happier. And the truth is we need help, and technology is the help, but technology needs good data.
That's fair. So everybody is the stakeholder.
I think if we do it right, and that's one of the things that people say, well, I don't see the cost benefit for improving data quality because it's not easy. Improving data quality is a lifestyle choice. It's not a project, but it's kind of like being healthy. And maybe I'm not the poster child for that, but I think it's about you invest the time, you invest the habits to get to a point, because at the end of that journey, you'll live longer, you'll be happier, you'll be healthier, but you're not going to feel it by next Tuesday. you're just going to be thinking, damn, I wish I could have a potato chip. So I think that it's really, we have to make a strategic decision as an industry, and we need to evolve. And we have to think about the long-term benefit and not just the short-term benefit.
Appreciate that. No, that's great. So, Charlie, as payers rely more on clinical data for decisions that affect reimbursement, quality ratings, even care coordination, what does a high-functioning payer data ecosystem look like to you?
I think a high-functioning payer data ecosystem is able to seamlessly fold in the claims data, the clinical data, the provider data, and essentially refine that information so that when they're looking for how to make sure that they're driving their members to making good decisions, they're driving the providers that are providing care for their members to making the right decisions about treatment modalities and services. I hate to be a broken record, but I think what really makes the difference is their ability to get the data, have it be good quality data, and fold it into an ecosystem where they can do meaningful things with it. And I think there's a lot of opportunity for that. There's a lot of people out there working on that. But at the end of the day, all these tools need ways to improve the data quality without requiring an army of people to go in and do that.
Totally. What would you say is different about the organizations that will succeed in this next phase of interoperability?
I think a lot of it has to do with people realizing that it's not like it used to be. Here's another thing about data quality. Somebody asked me the other day, whether or not something is good quality depends on whether you can use it. And I think part of the reason why people get stuck in a rut around data quality is the things we were trying to do 10 years ago, the data might have been perfectly fine for that. And what it means is that the people that have been doing this for a while have to wake up and realize that the hockey puck has moved down the ice, and we've got to change our perspective. I never do sports metaphors, so I'm not good at them.
That was pretty good.
Is that pretty good?
Yeah.
Does the puck actually move on the ice?
Yeah,
All right.
the Gretzky analogy.
Yeah, and then they get the touchdown. but I think that we have to, as an industry, and those teams have to realize that it's not the same old game it was 5 years ago. It's a different game now.
The game has certainly changed, and that's why we have conversations like these with leaders like you. So we could think about what's coming around the corner. And so let's talk about health systems. They depend on data to power care, operations, reporting, but accountability for data quality often falls through the cracks. What has to change culturally or structurally for data governance to truly take hold?
I think data governance without data measurement is an issue. So, data governance is another one of those statements that could mean 15 different things. But ultimately, what it becomes is it becomes a strategy from the systems that collect data, like EMR systems, which EMR systems all have their own dictionaries, and they're all built really for the operation of care. They collect the information so that you can bill. They collect the information so that you can schedule. And for a lot of these providers, there's a whole back office that tries to take that data and turn it into something more useful. And what I think today is not enough people have things in place to measure and understand what's actually happening with that data and whether or not they've refined it to the point where they can do things with it. So I think you can have data governance, depending upon what you mean by that. But there's a data governance for the data that you put into the system, but there's also data governance with how that data moves into these downstream platforms that use it, whether it's for quality measures, population health, value-based care, or some type of AI functionality. So they really have to think about that whole life cycle and how they can see how the data moves and changes and how they can minimize the amount of variability and latency that happens in that process.
For sure. And where my head goes on this, Charles, M&A, right? It's starting to pick back up again for health systems. Like, talk to that point. What should health systems in that scenario be thinking about from a data quality perspective?
I think when it comes to data quality, imagine if you're looking at two organizations and one of them has data liquidity. They're at a point of data liquidity where if they want to understand something about their organization, they know it, just like that. And there's another organization that if you ask them a question about what's going on, they say, I'll get back to you in 60 days. We have a client, a large, very large health system, that has really worked over the last couple of years to get to the point of data liquidity. And when a hurricane comes through, or when they're trying to figure out where the ventilators are, instead of being a 2-week process, it's a 30-second report. And that's such a dramatic difference in your ability to act. And also, ultimately, when you have data liquidity, you can start to understand things that are happening in the system that cost you money. Are we overutilizing resources? Do we have too many nurses in this place and not enough in this place? Once you reach that point of data nirvana, or whatever you want to call it, the data, this goes back to the infomonster metaphor, and we just collect data. It's a monster. You get this infomonster, and the idea is, how do you take that monster and turn it into something that is a truly active asset that helps you understand exactly what's happening in your system? So I just think that it's a huge advantage if somebody can do that, as opposed to somebody that's still doing things in a reactive way instead of a proactive way.
Yeah, that's brilliant. I love that. It's a big competitive differentiator, if you got it right.
Absolutely.
So the health conference brings together a diverse group of stakeholders across all sectors, providers, payers, life sciences, et cetera. In thinking about the life sciences sector, there's often a significant gap between the way data is captured in clinical settings and how it needs to be structured for research and analytics. How can better interoperability and data quality bridge that gap?
Well, just like when you're trying to use data for value-based care or anything else, and in life sciences, what you're doing is you're taking a cohort, you're taking a population of patient data, and you're trying to normalize it. When you think about a lot of the tools that get used for any kind of research, whether it's OMOP or whether it's CDISC or whether it's some kind of proprietary structure, to be able to do the research that we want to do to create real world evidence, it's all got to be speaking the same language, and it's all got to be data that is not broken in some way. Because it's just like anything else. If you have broken data, if you have data that's not normalized, if you have data, the bane of any use of data in healthcare is uncertainty. The minute we inject uncertainty, especially uncalibrated uncertainty, it makes us not trust, not rely, not believe the data, and that just results in what can be very expensive misfires. So I think it's one of the things that I think is funny, Saul. When you look across the different verticals, they all have the same problems. They use different names. They have different formats. They might have different focuses. But as an engineer, I'll put my nerd hat on for a minute. As an engineer, it's the same pattern over and over again, the same set of patterns. And so whether you're talking about a provider, a payer, or a life science company trying to do some kind of real world evidence or analysis, they're really all struggling with the same core set of issues. And they're all solved by the same core set of mindsets, guiding principles, and potentially technologies.
I like that you went down this path, Charlie. And what came to mind was, okay, so is there a parallel, a vertical, say finance or education, that has done a great job with this?
I think that I started my career in the finance industry.
Did you? Cool.
Absolutely. And what's interesting is, in some cases, people look at other industries like education, even things like criminal justice, whether it's taking credits and going from place to place and determining if they're the same, whether it's determining if the laws that are broken are the same from one place to another. Those problems exist. There's just not as much money there as there is in healthcare.
Yeah.
When it comes to things like finance, the ecosystem of sharing financial data, like when I was a young man and I worked in the finance industry, if you don't balance to the penny, people come after you with pitchforks and torches. In healthcare, they're like, you're missing his allergy. That's no big deal. When I started in healthcare, and I'm like, what are you talking about?
Yeah.
If I'm off by the penny, I get assaulted. But in healthcare, if I'm missing this thing that's an allergy that'll cause anaphylaxis, it's no big deal. Now, we've come a long way since then. But I think that the problem with healthcare, not the problem, but healthcare is very complex. So when people draw parallels between finance and healthcare, it's not a real fair comparison.
It's not.
It's like, I don't even know what it's like, because I've worked in healthcare for 35 years, and it's a complicated beast. And it's a real-time critical thing. It is not as simple as checking accounts and savings accounts and financial transactions. It is orders of magnitude more complicated, and it's disrupt proof. That's the other thing too about healthcare, because it's so critical that people that try to move into the industry and flip it over like they did in marketing, for example, the internet and things like that. I don't think you can do that in healthcare because it's just too heavy a table to flip over. The way we're going to evolve in healthcare is by making these slow evolutionary steps. And honestly, if I think about it, I would say the thing that could create an ecosystem where we could disrupt healthcare like we've disrupted other industries, like having things on your phone, it all starts with data quality. Because as a patient, if you're getting all kinds of data from everywhere and you're trying to aggregate it and even take care of your own healthcare, you go into 7 portals. Even if you're using the health app, you're getting all kinds of crazy duplicated stuff on your phone. That's because the data quality can't drive anything that is disruptive or evolutionary. And I don't know if that answered your question.
It does. Yeah,
but
for sure. Essentially, there's no parallels. There's some inspiration there and maybe that's where some of your inspiration came from, to the penny accuracy. And then you come to this side and you're like, man, this could be a lot better. But nevertheless, it's its own beast. It's 20% of GDP. It's a massive economy in its own.
We have to respect it and we have to figure out how to approach it. And I think, once again, we have to make the hard choice to invest in improving the quality of information and then start to do really cool things. And that'll snowball. I think that'll start to snowball use cases around better quality data that could lead to all kinds of amazing things down the road.
Super cool. I love that. Well, certainly inspiring, always inspiring to talk to you, Charlie. I always learn a lot. And of course, everybody with us on the podcast, I'm sure you're learning a lot too. And this is tip of the iceberg. Obviously, clinical architecture is doing a lot of great work in the space. So, Charlie, if people want to learn more about your company, your team, what you guys do, what's the best place they could check you guys out?
You can always go to clinicalarchitecture.com. I'm sorry that the domain name is so long, but the CA wasn't available.
It's clear.
And you can also check out the InfoMonster podcast if you want to hear me pontificate about things. And I should have you on my podcast.
Let's do it. Okay, I didn't know.
Oh, yeah.
All right. And we could link it up here, right? We could put it in the show notes.
Absolutely.
Oh, amazing. InfoMonster. So this is literally like tip of the iceberg to InfoMonster.
Oh, yeah. Yeah.
Wow. That's a nice surprise. Thank you.
No, you're welcome. You're welcome. If you're a big healthcare nerd, data nerd like me, that's the kind of stuff we talk about. So it could also put you to sleep.
You're either in or you're out.
Yeah,
right?
that's right. The dulcet tones of Charlie Harp. You drift off to sleep, hearing about SNOMED codes. Who knows?
You either use the Calm app or the InfoMonster.
That's right.
No, listen, for all you data nerds out there, I know you'll appreciate it. I always enjoy chatting with Charlie here at Health. Look at the show notes, everybody. Get all the ways to get in touch with Charlie, his company, download his podcast. Thank y'all for tuning in. And Charlie, thanks for being here. Thanks,
Saul. It's always great to see how a professional does it. Thank you for having me on. I really appreciate it.
My pleasure.